Welcome to the Surgery and Therapy Summit conversation with Katherine Butler. Kath, welcome, and thank you so much for spending a little bit of time with us.
Thank you for asking me, Robyn.
So I have known you a long time, and you have always inspired me, and I've been in awe of your ability to not only understand musicians the way that you do, but also being a musician yourself. You're able to work with these professionals in such a unique way. And during this interview, I would just like to find out a little bit about how you discovered music, discovered hand therapy, and how you merged the two.
I went to a performing arts school, and so from a very young age, I started playing music. I started with the recorder, as lots of music students do, and then played the flute, piccolo, then the flute, then the violin, and singing and dancing, doing ballet. So right from a young age, my family were performing artists.
Amazing. That is so. Okay, so are your parents musicians?
My mum was a pianist, and my dad's a very keen advocate for musicians that didn't perform professionally. But my sister is a professional bassoonist, and my brother-in-law is a professional clarinetist. Yeah.
Yeah, that's amazing, because I have a musical son, and he plays 3 instruments, but he does not get it from anybody in the family. So
it's often the case, actually, that people, I mean, some of my really well-known musician patients, their parents are not musical at all. I think sometimes it's an innate gift, and then other times people really have to work hard at it. And obviously some people do it professionally, and others do it for a leisure pursuit. So there's many, styles of playing and instruments, etc., and many reasons why people do pursue it or do not pursue music as a career.
Yeah, no, I do understand a little bit about it, because it's a complicated world for a musician to enter into. There are so many levels that their brain has to function alongside their hands. And also treating musicians, I have always found very, very challenging. It's particularly when you're a hand therapist treating a lot of trauma, and then the next thing, a professional musician walks through your doors. So it is a challenge, and I feel that it is such an important skill to learn, so that when that musician does come to you, you can offer them something of value. But before we go there, I would just like to know a little bit about your career, because you grew up in Australia, and you actually did 2 degrees simultaneously. Tell us a little bit about that.
So I did 2 degrees at the same time, moving from the University of South Australia, where I studied occupational therapy, to the University of Adelaide, where I studied flute. And I'd go from the dissection lab to an orchestral rehearsal. And it was this sort of marriage of performing arts medicine and music that became a passion for me right from the start, because I worked both as an occupational therapist and as a flautist when I graduated. And I just became more and more aware that musicians didn't understand their bodies too well, and medics often didn't understand musicians. So I was really, really keen to marry those 2 passions. And that's when I applied for a scholarship and moved to London to study performing arts medicine with Kitwin Parry and Ian Winspur. And I owe them so much, because they taught me so much, and they were just incredible mentors for me.
Tell us a little bit more about the scholarship. So what was involved?
So I applied to the Queen's Trust Scholarship, and I was awarded it. It was quite funny, actually. It's obviously a blinded application process, but my sister was awarded it the year before to study bassoon in Freiburg in Germany. And then I was awarded it the following year to study performing arts medicine in London. And it was a huge honor, because I'd read Kit and Ian's book, The Musician's Hand, so many times when I was working as an occupational therapist in Adelaide. And I just thought, I really, really want to pursue this, the marriage of music and performing arts medicine. So I wrote to them a really shy little letter, both of them, saying, I'd really like to, work with you guys, and would that be possible? And it was a bit like writing to God. I was like, oh my goodness, this is, and then I thought, there's no harm, I may as well send this letter. And then I got really lovely replies, snail mail, because it was 24 years ago. And and they both said, look, they'd love to have me come over. London's expensive. I needed a scholarship and to apply for one. So that's when I did apply for the scholarship, and I got it and moved to London.
That's a great story. I love that. And I love that, it was handwritten letters. Okay, so you arrive in London. What was it? What's the Performing Arts Medicine Centre like?
So British Association of Performing Arts Medicine is, I think it's pretty unique actually in the way it's set up. Historically, it was a lot smaller. Now it's a lot bigger. We used to be based just on Shaftesbury Avenue, and it was a beautiful old house, and we had the whole house and, waiting room on one level, and then consulting rooms upstairs. And my very first clinic there, I thought I'd learn from the master, Kitwin Parry. No, he sat in the corner and said, you are running this clinic. So right from day one, I was in British Association Performing Arts Medicine Trusts rooms, running clinics with Kit sitting in the corner. Wow. So it was a bit of a shock. And but it was amazing, because he'd take notes and he'd talk to me about, what I did and what I didn't do, et cetera, and he'd really sort of try and support me. And that's why I really respect him as well. He was just so generous with his time and with his knowledge. And we became really, really close friends, and also with Ian, and did a lot of traveling and lecturing and publications, etc. together. And nowadays it's a much bigger organization, and there's many more people doing performing arts medicine. And actually, I'm an associate professor at University College London, where there is a master's course in performing arts medicine. So that has been set up on the back of wanting more people to know about how to assess and treat musicians.
Wow, I love that. How incredible. So tell me a little bit more about the whole team that's involved with a musician at the Performing Arts Medicine Centre.
Yeah, so I think often, obviously in any area of medical management, a multidisciplinary approach is really important. The team with musicians can be a little bit different. So it could include a neurologist, a hand surgeon, rheumatologist, instrument maker, instrument teacher, psychologist, a specialist musician who is used to rehabilitating people with for example, a pianist, a specialist pianist looking at a pianist condition and working with me. So it can be a really, really big team. I think what happens with BAPAM that's really important is that a musician can ring in and get some advice for free over the phone and get assessed as to whether they need assistance with their mental health or physical assistance. And then there's a register where you can then be streamed into physical rehab and assessment, or mental health or housing issues, etc. So it's quite holistic and enables patients and musicians to try and get back into the workplace, but also to get assistance quite quickly, because often if you can provide a diagnosis for a musician quite promptly, then there's a lot of issues that are resolved around fear and around, will I ever get back to playing? What condition do I have? How's this going to impact my career? Also, I think the big thing with musicians is that it's such a part of their social life. If they don't have their instrument to relate to and to go out to do gigs, then they can get really worried, but also financially, obviously, there's a huge impact. But it's so much part of their personality and part of who they are, that if they don't have that outlet, it can be pretty frightening.
Well, it's almost like losing your identity and you're completely frozen in fear. And is it government funded or supported? Because it would be really expensive to attend a center where you're needing to personally pay for all of those specialists. So do they get help with their funding, or is it private or not?
Yeah, so the actual BAPAM is funded by a lot of charity work. So, you know, the proms, people donate into boxes and buckets that they shake. And then there's a lot of legacies left. So people leave their estate or part of their estate to Harp Musicians UK or Royal Society of Musicians, who are bodies that BAPAM refer into. So for people to come and see me, they can apply for a scholarship, and then they don't pay, the third party settles with me.
Okay, well, that's great, because then they can get the help that they need.
Yeah, and they also don't have to pay for it. Yeah.
Okay, and then you've done a lot of research. Tell us a little bit about your special interest within the field.
Yeah, so I particularly was interested, and actually Kit put me onto this, and sometimes I am a bit cross that he did, but he said to me in some of our very early clinics, he said, well, after seeing a patient, he said, well, what do you think's wrong with them? And we discussed it, and eventually we decided the musician had dystonia. So this is back in 2004. No, actually even earlier. This was back in about 1999, because I started my research in about 2002 into musicians' dystonia. And we decided this patient had musicians' dystonia. And there was very little work done on how to assess it, how to diagnose it, how to grade it, what treatment techniques, management techniques there were. And actually, predominantly, historically, people have thought that it's a psychiatric condition. But now, obviously, we know that it's a neurological condition. But he set me up with the mission of solving the task-specific dystonia problem. And actually, back then, it was called focal dystonia. Okay. And so my husband jokes around, because I've been doing this research for so long, that the actual condition has changed its name.
You know, you've got to love our husbands. They know our work so well. They could almost be us.
I often want him to present for me.
Exactly. Okay, so that is incredible. I mean, 1999, that's a long time. So you've really been there through the decades to see where it is today, but you have been instrumental, excuse the pun, in contributing to the literature and the understanding. It really is amazing.
I've been really honored to work with some incredible team members, and I've worked with people who are neurologists, neurophysiologists. Obviously, we have the musicians and the non-musicians that are age and sex and level related for music playing. And so the research has happened for many years now, but thankfully and happily, we're finding ways, evidence-based practice, so that we actually do know what works, what doesn't work. And obviously that's on an individual level as well, but we at least know what does work, what doesn't work for the population group that we've been working with. Yeah. I've got probably about 140 people that I've seen with musicians' dystonia, and that cohort's really useful, and they've all signed up to be part of research projects, because that group, it's a pretty rare, mysterious condition, and they're very keen to help other people know how they can get better. Not everyone does get better from this condition, so they may have to play different repertoire, or they may have to adjust to doing more teaching rather than performing, or adjust their repertoire in terms of maybe also changing instrument or becoming a conductor. And then some people just decide to actually go into a whole different space. You know, one of my patients has decided to go into redeveloping properties, and because they're at such a high level of performing, and they knew that they would never get back to that level. So for them, they thought, well, I've played, you know, in most of the leading halls in the world, and I actually want to change now. So, and I respect that hugely. Yeah,
they're ready, and they can always pick up the instrument and play for their own therapy and their own mental health.
Yeah, I mean, sometimes it's too heartbreaking once you've had an injury, and if you've not been able to play for a long time, often, and I find this often, if you can't play for a long time due to illness, or if you can't play due to other commitments, your level does slip anyway, and then it doesn't become so enjoyable because you're not producing a sound that you used to. But I think also because the very severe dystonic patients, they often can't even think about playing music without getting dystonic symptoms. So even the idea of playing brings on their symptoms.
That's huge. And that's why I suppose it's been labeled a psychological disorder in time.
Yeah, and I think, I mean, obviously, if you've got an incredible passion, but also your whole work is on making music, the people that get dystonia tend to be at the peak of their career. And if you've got something like that, and then it renders you unable to play at all, then the actual depression or anxiety or underlying mental health issues are due to not being able to play. So they can become a secondary condition due to the shock and the inability to play, that means that they themselves have lost their identity and their ability to earn. So it's not a psychological condition, it's a neurological condition, which then plays out physically, in physical manifestations. But often you do get secondary anxiety, depression, and that's when I refer sometimes onto psychologists.
So it's such a multifaceted approach that you need. And tell us a little bit about the treatment methods that you designed and implemented and also researched, and how you were, by having access to the neurologists and neurophysiologists, you were able to really determine if your treatment was effective. Tell us a bit about that.
Yeah, I mean, I think there's been a lot of research done into sensory motor retuning, which is a splint that you can fabricate to block the compensating finger, enabling the dystonic finger to do repetitive movements and retraining. Mirror therapy, obviously, you can use very well with pianists in particular, because their movements are fairly symmetrical. And then there's also, Nancy Bill's done a lot of work looking into sensory re-education, really looking at the sensation, what the musician is feeling, and then the motor response to the feeling, and retraining that neurological map loop within the somatosensory cortex, which is the hand representational area in the brain. And then there's also slow down exercise therapy, which is really looking at making a movement mechanical rather than emotional to enable retraining. And so those research projects have been done really in a scientific, with small numbers of subjects. And so they're really useful to think about and look at. But we've done research looking into an actual population group. Is it feasible to implement a multiple rehab approach using all of those treatment techniques that have been presented, but also other things such as soft tissue massage, lengthening exercises for tight muscles, shoulder exercises to get more freedom proximally, because often if someone's working with a hand that's dystonic, they can get all sorts of compensatory movements that then lead to an inability to have the hand in a functional position for playing the instrument. So yes, so we've done some interesting projects. Some of them are literally looking at my patient group and what treatments they've found effective, because a lot of research projects are looking at what we do to patients and how that affects them, whereas I wanted to know why they thought they had dystonia, what treatments they've tried, how they've found them. Do they actually have symptoms during daily life, brushing their teeth, doing their hair, etc., or is it just task specific when they're playing their musical instrument, for example? So that has been one project. Another one was looking at this rehabilitation approach and how it could be incorporated into a public health setting where maybe you don't have as many sessions as if you're in a private clinic and the patient's being assisted by a funding body. And one that's been quite fun, also quite challenging, is looking at the sensory motor cortex in musicians who have dystonia and musicians who do not have dystonia. So we trained using a special keyboard that we developed. We trained musicians into playing a very set piece. And then we analysed the musicians who were age, sex and competency matched, playing that in the MRI and analysing their brain as to how coordinated their movement was, et cetera, and then we did analysis of the somatosensory cortex. I didn't personally do that because I don't know how to do it, but and then we looked at, after doing a rehab program, how that had changed. So that's just been sent off to a journal. Hopefully it'll be accepted, who knows. And so that one's interesting. And I think also there's something called a MIDI, which is a musical instrument digital interface. And that's something that we use in terms of knowing the precision of the movement, how hard the person's pressing the key. And you can also set these playing techniques that you look at the coordination between the instrument notes, etc. And so that's useful. And with writers, we have an iPad type setup where you can look at how much pressure they use to do the writing and the fluidity of the movement and actually the compensating movements as well.
Wow. Now you are a busy lady, but it's so lovely because you have published so extensively. You've also published your chapter in the rehabilitation of the hand and upper extremity textbook in this latest edition, well, and the ones before. And so there is a lot that we can learn by reading your work, but actually having you present at the summit is going to be so unique for us because you're running a workshop so that you can help therapists at least gain a little bit of competency. Tell us a little bit about what you're going to be teaching us at the summit.
I thought I'd focus on task-specific dystonia because that's what a lot of my research is in. And I want people to know how to assess it and diagnose it, how to treat and manage it, and who gets it and why. And then some little nuggets as to the research that I've done in terms of what treatments patients do find help them and what don't, so that there's an evidence base to their treatment programs. And I think if we can demystify this condition that often people find difficult to diagnose and then feel quite lost in treating, then at least that patient group will have, people who know a little bit more about the approach that has been researched and worked on in my team. Yeah.
It's so valuable because then we can direct our resources within the clinic to those patients and not waste time because we have a reference. You say, right, this is evidence-based, and so this will work. In our experience, this doesn't work. Let's not waste time with that.
Yeah.
Do you have any guidance or ideas on how to strengthen a musician? Do you focus on the proximal joints and kind of back and core? Do you include that in your programs?
Yeah, very much. I think it really depends on why they're coming to see you. If it's more of a overuse syndrome or work-related upper limb type presentation due to either having an increase in difficulty of repertoire or an increase in playing or an instrument setup that's not quite right, therefore they've had nerve compression issues or pain due to muscular tension or pins and needles, etc., you take a very holistic view. And yes, I do a lot of Pilates with my musicians and teach them that. And then if they can, then they go on and do reformer Pilates separate to me. I do look at hypermobility a lot with the musicians because there's a much higher percentage of musicians that have hypermobility. And you look then at their posture when standing, sitting, playing in different positions and using different supports, neck support, you know, a peg that they may support the instrument weight onto the chair or the floor. And yeah, so it is very holistic when dealing with that sort of patient group. Sometimes if they just come in with a straight wrist fracture, people might think, oh, okay, this rehab's just to do with getting movement back, but it's not. You need to use the instrument as the rehab tool. So with a violinist, they use a lot of supination, a lot of wrist flexion, and you've got to have a lot of fluidity in the movement. And so, yeah, it's very holistic and instrument focused, and getting the person back on the instrument as soon as possible and as soon as is safe, obviously.
And of course, it's always been a notion in my mind that one would limit any kind of surgical intervention unless it's absolutely necessary. And there are, our rehab approaches are certainly improving, whereby surgery is often just not the answer. And so the most important person in the team is you.
It's Ian and I did research into 130 of our patients, looking at who has surgery and who doesn't, and encouragingly it's only about 10% of musicians that need surgery, and they're the ones that have trauma or that they have a nerve compression, a true nerve compression. So obviously you can get a nerve compression that's due to postural issues such as guitarists playing with too much wrist flexion, or people typing with their wrists extended on the hard work surface. Or you can have, so that's a functional nerve compression, or you can have a true nerve compression. And if they have a true nerve compression, then they'll often require surgery in order to be able to play and get back to performing. So what was your question again? Sorry.
Yeah, so no, you've answered it. So just, it's a very small percentage that
exactly. You try and avoid it, but if you do require it, then it needs to be done very specifically and very carefully, and preferably by someone who has experience with operating on musicians. And then the rehab post that is really, really important.
Well, your workshop is going to complement Aviva Wolf, who is your colleague. And what is so wonderful about her workshop is that she's going to be running through all the different instruments with us so that we can understand, first of all, what that instrument is and how the patient normally postures with that instrument, and then looking at what the kind of problems develop with that instrument. And she's going to be giving us a nice downloadable checklist, and then of course the treatment. So it will be lovely to have her session where there's an overview, and then your session where we are being a whole lot more specific. So it's very exciting. Thank you so much for your contribution.
Pleasure. Thank you for asking me.
To the summit. And yeah, I think that pretty much covers it all. I'm sure that after the summit, there might be an opportunity for a Q&A. So those who attend the workshop, maybe we'll be able to get online and do a little Q&A, which might help a lot of people, just in terms of, you know, specific questions with any patients that they're currently treating. But thank you for your time and sharing your expertise, and we look forward to learning more.
Thank you.
Thank you.